How's it going, guys? So this is a very easy question for ophthalmology for internal medicine for 2CK, this spot diagnosis here. I'm not about being fancy and overly creative and gotcha. I mean, the point is to increase your fucking score in the least amount of time possible, all right? So we're cutting to the chase. And for step one, I mean, this is fair game, okay? So before we get started, please subscribe to my channel. I really appreciate it. Give the video a thumbs up, really appreciate it. And find me on Instagram at Melman_medical, MEHL_medical. Link is down below. And find us on Telegram. Recently created a Telegram group and channel. Links are down below. Now, hopping into the question here, 39-year-old woman. She has a 3-day history of blurry vision and pain in her left eye. A fluorescein installation of the eye is shown below. Fluorescein is an orange dye that when applied topically to the eye and viewed under a UV/violet light, normal areas will appear blue. Areas that are structurally/topologically disturbed will appear green, okay? Abnormal areas are green. So here you see what appears to be a dendritic structure, okay? Very high yield spot diagnosis here. So why don't we just walk through some of our answers. Tanometry, wrong fucking answer. This is a pressure study of the eye, which is used for glaucoma, okay? If you get a question on the USMLE, if they give you open angle glaucoma, which is painless, loss of peripheral vision over many months, you do tanometry, okay, pressure study, look for increased intraocular pressure. 12 to 21 millimeters of mercury is normal. If you have a closed angle glaucoma, which is a very acutely painful eye, red, with a mid-fixed pupil, so that's closed angle glaucoma. Before you hop into treatments, okay, tanometry is what USMLE wants. High yield for 2CK, but not the answer in this case. Pilocarpine, wrong fucking answer. This is a muscarinic receptor agonist that's used for acute angle glaucoma, okay? So as I just described with the painful red eye, after tanometry is performed, topical pilocarpine, very fucking effective, okay? It increases tearing, okay, decreases intraocular pressure. IV 0.9% normal saline, wrong fucking answer. I threw that in there because this is a very common/frequent answer on 2CK for a myriad of questions, okay? Patients who are in the hospital for pancreatitis, autoimmune disease, like various conditions, okay, across the board, and they want you to think about ABCs. IV normal saline comes into play a lot. So you say, I'm not really sure, would I choose saline? Not in this case, all right? That's a lengthy discussion. Ganciclovir, wrong fucking answer. This is for CMV, okay? So CMV retinitis. If they told you, for example, an IV drug user, HIV, okay, CD4 count under 200 especially, you can think of CMV causing retinitis, which would be blurry vision in an AIDS patient. That's when you would give ganciclovir, all right? Dicloxacillin, wrong answer. This is a classic agent used for skin infections, okay, and as well as mastitis. It's a methicillin class beta-lactam that is effective at covering both staph and strep. That's also a lengthy discussion, okay? If you give penicillin or amoxicillin alone for skin, for instance, it won't cover staph, okay, because staph produces beta-lactamase, MSSA. So you want to give dicloxacillin. Wrong fucking answer, as I just said. So carbachol, also not correct. This is a muscarinic receptor agonist similar to pilocarpine that can be used for open angle glaucoma, all right? It's not what we want here. Vivacizumab, okay, this is a juicy answer. This is a vascular endothelial growth factor antagonist, okay? And this can be used for neovascular age-related macular degeneration, okay? It can slow blood vessel growth. Now, when you look at the dendritic structure and you say, no idea what the fuck this is, I mean, some students could opine that maybe this is something related to blood vessel formation, okay? Bevacizumab, a VEGF inhibitor. Not the correct answer in this case, just clearly a distractor. Bethanechol, this is a muscarinic receptor agonist, classically used for hypotonic bladder in diabetes, okay? You get neuropathy to the bladder, overflow incontinence, high post-void volume, and you can give bethanechol to stimulate detrusor muscle, okay? The opposite of oxybutynin, which is a muscarinic receptor antagonist used for urge incontinence. Our correct answer is acyclovir, okay? This is herpes keratitis caused by HSV 1 or 2, okay? This dendritic structure, exceedingly high yield as a spot diagnosis, okay? We use acyclovir here, topical and oral, all right? USMLE is not going to force you to choose topical versus oral for this situation. If you had to choose, you would choose topical. I mean, it's the fucking eye we're talking about here, but they're not going to do it. Don't worry. You can also be aware that this dendritic structure, not just HSV1 and 2, but herpes viridae in general. I mentioned CMV retinitis before. You won't see it for that necessarily. It's more for VZV. Okay, you can get herpes. Herpes zoster ophthalmicus. Okay, so herpes zoster being the other name for shingles. So herpes zoster ophthalmicus, VZV, can present with this dendritic structure, okay, of the cornea, all right? CMV retinitis, different, okay? You're not gonna have this corneal dendritic structure here, but acyclovir as well for both VZV, for herpes zoster ophthalmicus, as well as HSV1 and 2 for herpes keratitis. You know the deal. I'm going to continue making more content. If you like my stuff, subscribe to my channel, and I appreciate your time. That's it.